Hi, I'm Professor Mark Parsons. I'm Professor of Neurology and Medicine at UNSW. I'm a neurologist at Liverpool Hospital in southwestern Sydney. I'm involved in many areas of research in stroke, but in particular in acute stroke, looking at improving acute treatment for stroke, particularly around removing the blockage from the brain that causes stroke, looking at better techniques, better brain imaging to identify patients with this condition, working with, particularly in the pre-hospital domain, with ambulance services and paramedics to better identify patients before they get to hospital so we can get them to hospital and treated more quickly, looking at new models of care around faster access to acute stroke treatment, lots of clinical trials around new methods to dissolve the clot or remove the clot, and lots of other clinical trials around implementation of new models of care. So mechanical thrombectomy is where we actually go in through the arterial system and remove the clot, typically with what we call a stent retriever. So a stent is deployed in the vessel with the blockage, and the stent is then removed with the clot or the thrombus inside it, so it's taken out of the blocked artery. That restores blood flow and hopefully causes minimal damage to the brain. The problem is the longer the clot is there, the more damage occurs to the brain, and the worse the outcome. So the earlier that you can remove the clot, much better the patient's long-term outcome. And this treatment is probably the most powerful treatment in all of medicine, not just in stroke or brain. This condition that we call large vessel occlusion stroke, where there's a major artery to the brain blocked by a clot. Before we had mechanical thrombectomy, the majority of people with this condition would end up with a severe brain damage and often would require nursing home care or be fully dependent for all of their basic activities of daily living, like dressing, feeding, etc. With this clot retrieval or mechanical thrombectomy that's become available since the trials that were involved in 2015, now every 2 or 3 patients that we treat is almost cured and at least gets back to a normal independent life at home and back to work or back doing their regular activities. So it's a really dramatic treatment that has really changed, I think, not only patients' outcomes but also the way that we manage stroke, and that's why we're looking so much at better models of care to improve all Australians' access to them. The problem with mechanical thrombectomy is it's very resource intensive. You require skilled operators, a support team, a properly set up angiography lab where you and this can predominantly be only resourced in a few centres in each state. So that then means there are problems with access of people that live a long way away from these centres. So we're doing a lot of work on trying to improve rural and regional Australians' access to this really dramatic therapy. There are robots out there that can do mechanical thrombectomy. You still need a human operator to puncture the artery to get the robot set up and to pull the clot out, but you don't necessarily need to have the expert operator for the neurointervention. They can do it remotely. The Gold Coast Hospital, Royal Melbourne Hospital and Liverpool Hospital are about to start a clinical trial looking at remote thrombectomy. The main issue is you still need to have the device in a larger hospital and transport the patient there. The device will never go out to a person's home, for example. You still need a proper setup, a catheter angio lab setup. I think if you look at our thrombectomy rates per capita, they're actually relatively high compared to most countries. There are a lot of course, very large countries, like for example in South America, where patients still have no access to mechanical thrombectomy. So we're probably, in terms of per capita numbers of patients treated with thrombectomy, probably in the top 5 in the world, but most of the patients live in cities that get access. The rural and regional Australians are getting increasing access, but the problem is the delay. How do we speed up the time to thrombectomy? There are many processes that we need to look at to improve that, but the transport delays are the biggest one. So any way we can get the patient more quickly to a thrombectomy centre, or to get the expert interventionist more quickly to a centre near the patient, we really need to work on that hard. I think that's the biggest. This rural metro gap's obviously not just a problem in stroke, but it's highlighted because we've got a time critical treatment, and there's no doubt that rural and regional patients are getting treated later than their metro counterparts. There's a few different models of care that are possible and we're looking at and testing. The simplest is what we call stroke capable ambulance, where all ambulance personnel are trained to recognise large vessel occlusion stroke, and that might be with the assistance of various sort of apps or tools that help them make the diagnosis and make a decision. We're working through the Australian Stroke Alliance using an app that's been developed in collaboration with the Stroke Alliance and a small startup company called Titan that has developed this communication decision assistance app that we're using in various settings, currently in southwestern Sydney, where it's been incredibly successful, improving times to mechanical thrombectomy from stroke onset time, but we're also testing it in Melbourne and regional Victoria, and also in the Hunter region, with plans to expand soon to South Australia, Queensland, and some other regional areas in New South Wales and Victoria. So that's I think something that can be rolled out across all states and ambulance services. That's a relatively simple model of care where the paramedics identify large vessel occlusion stroke and communicate directly with the relevant comprehensive stroke centre that provides mechanical thrombectomy, and then there's a direct transfer to that comprehensive stroke centre rather than going to another hospital that doesn't have mechanical thrombectomy, because of course then that slows down the whole process. There's lots of other things we're looking at around that, because for regional and rural Australians we also need to sometimes consider whether we need helicopter or air transport as well. So there's lots of parallel processes that we need to look at. The mobile CT that you talk about, that's quite a relatively expensive model that probably wouldn't be cost effective in smaller populations. So we're looking at more portable brain imaging that can be rolled out in regular ambulances. A CT equipped ambulance is often quite a large vehicle, and because of the cost to run it, probably is only cost effective in a sort of densely populated metro area rather than rural or region. So we're looking at more like inexpensive portable devices, some of which are X-ray based, some of which are microwave and brainwave based, and some are even based on MRI technology, which I think is the coolest one of all. So we're looking at all of those as portable imaging techniques which would assist the ambulance team to improve what we call the specificity of their diagnosis, so when they identify a patient as a large vessel occlusion clinically, and with the Zeus tool, if they've got additional brain imaging that says yes, this looks like a large vessel occlusion, then it's much more effective process, because it means that nearly every patient you transfer will have a large vessel occlusion, because there's a lot of resource implications for, particularly for rural and regional. If you're using helicopters and fixed wing aircraft, it's quite an expensive process. You want to make sure you've got the right patient, and the ultimate is to get the right patient to the right hospital in the fastest time. But you've got to look at the costs and weigh up. Getting more accurate diagnosis is, I guess, the most important thing in the field that we're working on now. Another model of care which, again, we're exploring is the concept of actually, rather than taking the rural patient to a bigger centre for clot retrieval, which might be hours away from family and friends, is actually flying the interventional team out to the region and setting up some of the larger regional hospitals to be mechanical thrombectomy capable. Because currently the vast majority of mechanical thrombectomy capable centres are in the capital cities in Australia. There's currently one outside of a capital city at John Hunter in Newcastle, which is services the whole of northern New South Wales and extremely busy. But we'd be looking, for example, at other regional centres where they have some facilities already for cardiology procedures, and enhancing them so they can do the mechanical thrombectomy in the brain. But you still need the skilled operators, and they would have to be transported there. So we're looking at that model as well down the track. So there are various models that we're looking at, either getting the patient more quickly to the Comprehensive Stroke Centre from a rural region, or possibly maybe getting the interventional team closer to the patient. They obviously wouldn't be going to every hospital in regional Australia, but we could potentially set up some of the larger regional centres as mechanical thrombectomy capable, even if the operators aren't there all the time. The operators might have to be flown in. Having said all of that, Townsville has just started up a regional mechanical thrombectomy centre, so we are slowly winning in rural and regional Australia to improve access to thrombectomy. All of our research always involves a health economic assessment, but in basic terms, if somebody's left with severe disability after a stroke, the cost just in dollars is at least $200,000 a year to the community, and that doesn't really factor in family and personal costs. So if someone's left with that disability for 20 years, that's many millions of dollars for one person. We have 15 to 20,000 large vessel occlusion strokes a year in Australia. So if, for example, 50% of those patients are left with severe disability, my maths isn't good enough to work that out, but that's billions of dollars that costs our community and governments. So it's actually a very simple equation. All of these new models of care, of course they cost money up front, but in terms of long-term cost savings, I don't think there's any other medical intervention that could show the same cost savings that we can show with this procedure, because the prevention of disability is so powerful. And we spend, quite rightly, billions of dollars on trauma and fast access and retrieval. It's not really fair that stroke isn't considered on the same level as, for example, trauma. And I guess trauma often happens to younger people, and people perceive stroke as being an older person's disease, but that's simply not true. 50% of people with stroke are under the age of 50 now. The majority of people that have stroke are still of working age. So the health economic impact of stroke is massive, and it really should be considered the same as other hyperacute, high priority conditions such as multi-trauma. But the cost savings are undeniable. It doesn't matter whether you're good at maths or not. The savings are in the billions of dollars. But of course, because our health system's state funded in the hospitals, but then in the community it's federal funded, it's difficult to convince state governments to fund these initiatives, because they're not looking at the long-term cost that the federal government has to wear. So it has to be a federal program ultimately to drive this change in collaboration with the state governments, I guess.